Good day, sir. We are Group 3. We are here to present about cystic fibrosis. Cystic fibrosis is actually a hereditary disorder. It affects the lungs, digestive system, and other part of our organ. The sticky and thick secretion will cause the airway to obstruct. So it happens to be the cystic fibrosis. So in formulating clinical questions, we have come up with two clinical questions with the formula of PICO. PICO stands for population plus with intervention plus with comparison and also outcome. So the first question will be effectiveness of positive expiratory pressure PEP compared to postural drainage PD in airway clearance for patient with cystic fibrosis. In this, the P stands for population, is the patient with cystic fibrosis. The intervention will be BEP or known as positive expiratory pressure. The comparison we chose was postural drainage, and the outcome will be the airway clearance. So second question is, which is more effective between chest physiotherapy and exercise in improving aerobic capacity among patients with cystic fibrosis? In this also, our patient or population is the patient with cystic fibrosis. The intervention will be the chest physiotherapy and the comparison will be the exercise. The outcome will be improving aerobic capacity. So we were searching for literature. We found three articles. One is randomized control trial, systemic review, and also clinical practice guideline. So the RCT title that we have found is the effect of postural drainage and positive expiratory pressure on trachobronchial clearance in cystic fibrosis. The SR title will be positive expiratory pressure for airway clearance in people with cystic fibrosis. Lastly, the CPG will be used for question number 1 as well as question number 2. So the title will be Standard of Care and Good Clinical Practice for Physiotherapy Management of for cystic fibrosis, the third edition of April 2017. Lastly, from my part, RCT and systemic review that we found in Pedro database is why? Because Pedro provides more reason, recommendation and also article based on medical site, and it is free, no subscription is needed. It also gives the option of simple search or advanced search. If we need a brief article, we can go for a simple search, and we want an imported and if specifically based, then we can go for the advanced search in Pedro database. And finally, there are also articles posted which was appraised by experts and other researchers in Pedro database. Thank you.
I'll be take over the next part, which is the appraisal of the evidence. So our group is came up with a clinical question of how effective is positive expiratory pressure compared to postural drainage in airway clearance for patients with cystic fibrosis. So this is our first pick-up question. So for this, we have choose randomized control trials to appraise and to gather information evidence prior to our clinical question. So we have choose RCT article which is titled as the effects of postural drainage and positive expiratory pressure physiotherapy on bronchobronchial clearance in cystic fibrosis. So for this article, we have choose a Pedro's core appraisal tool to appraise and to score this article. So according to the Pedro's core appraisal tool, this article has been scored as 7/10. Okay, the next thing, let's move on to the main findings. So there are two main findings. The first is the mucus in the airways of the patient with cystic fibrosis is clear significantly faster than 20 minutes of PEP with FET and postural drainage with FET and follow up with no treatment. And the second thing is we also found out that there is no statistical difference between these two treatment groups. I mean, PEP with FET and postural drainage with FET regimens were observed. Okay, let me move on with the strength and the weakness of this particular RCT article. So I'll be talk over the strength before I jump into the weakness. So the strength of this particular article is, as I've mentioned earlier, according to the Pedro score, uh, this article, according to the Pedro scale, this article has been scored as 7/10, and which is considered as a good article. Okay, the second thing that we have found out that the participants, those who have been involved in this study, have been blinded. It means there's a single blinded activity case. And the third thing is the intention of the therapist or of the researcher is to treat all those patients. So before they start treating the patient, the researcher or the therapist have collect the data of the participants. So okay, let's move on to the weakness. The weakness of this particular RCT is the therapist and also the assessors are not blinded, which shows there will be high chances of biases to take place, and also the outcomes might be more favorable to the assessor or to the therapist. And then we also found out that there is no allocation concealment take place. Okay, let me move on with the evidence of choosing this RCT. Okay, the first thing is, as I keep on mentioning earlier, this RCT has been chosen according to the Pedro scale, and we have appraised it, and also it's scored as 7/10. So the main reason why we have choose this particular RCT article is because the aim of this RCT article is to identify the short-term effect of postural drainage with forced expiratory technique and positive expiratory pressure with forced expiratory technique in order to clear the thrombobronchial region. We are sorry because there is a typo error because there's repetitive fate of words which is postural drainage with PD. It means it's only one meaning, it's postural drainage with FET. Okay, the reason we choose is because of this aim. Why? Because our clinical question and the aim is to, our clinical question is how effective is positive expiratory pressure compared to postural drainage in airway clearance for cystic fibrosis. So our aim is to clear the airways. So the second reason that we have chosen this article is because the allocation of the participants. The participants are allocated according to the randomized, single-blinded, controlled crossover trials, which means this will be helped to reduce participation bias, and also help to reduce systematic errors, and the outcomes will be more reliable or more accurate. Okay, besides that, the other reason that we have choose this article is because the patient, those who have involved in this study, have been grouped into different categories. So it means the first group will be positive expiratory pressure with forced expiratory technique. Second group will be postural drainage with forced expiratory technique, and the third group will be control group. And the other thing is all the participants are blinded, so it means they doesn't know that they are they are into which group. So it shows that there will be no back off of the patient, withdrawal of the patient in this study. So the result of this study will be can shows differences. It means we can see the differences for each groups. So that's what I mean. The other reason is the result is saying PEP is effective than postural drainage. As the evidence in this RCT, it shows that positive expiratory pressure is effective for 3 hours rather than postural drainage, which is only effective for few minutes. I'm sorry, there's a typo also. After the effective, there's no off. It's supposed to be for 3 hours. Okay. Let me to move on to the second appraisal evidence is systematic review. So for this systematic review, we have choose the article which is positive expiratory pressure for airways clearance in people with cystic fibrosis, and we have choose CASP tool to appraise this article. So according to the CASP tool, there's supposed to be 11 elements. So, but then the score is supposed to be 10. So in that case, there is 9 yes and 1 no for this question. For this particular article. So the findings of this article is we have found out that PEP is supported by a large body of evidence to use as a stand-alone airway clearance technique in cystic fibrosis. The other thing is the PEP is also recommended by some evidence as more acceptable intervention for long-term rather than other forms of physiotherapy for people with cystic fibrosis. And we also found out that this PEP is equal to other compared techniques. But a few long-term studies suggest that PEP is more superior to the other techniques. For example, for like our clinical question, PEP compared to postural drainage. So it means now the long-term study is showing that PEP will be more effective than postural drainage. So that's what we are trying to mean there. Okay, let me to move on with the strength and the weakness of this particular systematic review article is the main strength is this article is very positive towards our question because there is 9 yes to this clinical question according to the CAS tool. And all the criteria in this study were met, especially the inclusion and the exclusion criteria. The inclusion and exclusion criteria are very important in systematic review articles. So third thing is we have found this article in Cochrane database, which is more prescribed for SR articles. It means like we can use Cochrane database to find out systematic review articles. So and also this systematic review article that we have chosen is explained about the devices of positive expiratory pressure for cystic fibrosis patients. So let's move on with the weakness of this particular article is there is no relevant studies included, and there were no follow-up list or personal contact with experts have been listed down in this article. Okay. Reason of choosing this article is because, as I've mentioned earlier, this article is found through the Cochrane database. Okay, the reason that we have chosen is the author of the article has came out with a conclusion saying that PEP is more effective in training airway clearance and to reduce pulmonary exacerbations. I'm so sorry for that. And then it also answered the clinical question and consider the importance of the outcomes very well. And then these articles are reviewed. This article is reviewed in RCT. It means once we get the result in our RCT, and then we proceed with systematic review searching so to get a more evidence prior to our clinical question. So and also this systematic review article have been give more importance to the published and unpublished and so sorry, I'll repeat it again. I mean, this article if pay importance, give importance to the published and unpublished, and those things have been included as well. And then the result of the outcomes are more favored to the positive respiratory pressure. As I've mentioned earlier, the conclusion of the author itself is PEP is more effective in treating airway clearance. So, okay, now let me to move on with the clinical practice guideline, which means CPG. So, our CPG article is known as Standard of Care and Good Clinical Practice for Physiotherapy Management or Cystic Fibrosis. So, we have used agreed to domain scores to give a score. There will be appraisal will be there, so they will be give a score according to the domains. So for that, there's supposed to be 6 domains. So for the first domain, we have came out the overall score for the first domain is 47.2%, and for second it will be 26.9%, and third will be 43.4%, and domain 4 is RASI for IELTS number, which is 92.6%, and domain 5 is 84.7%, and also domain 6 is RASI 100%. So move on to the main findings. Okay, the main finding is low pressure positive expiratory pressure is usually performed in sitting position, but it also can be performed in various positions, such as you can put the patient in supine or side lying. Side lying, but our focus is to clear the airway clearance, and we have to focus through the area that we're going to clear the mucus. So this will be to increase the ventilation actually. So the low pressure PEP and other airway clearance modalities with reference to forced expiratory volume in 1 second of FEV1 demonstrated no significant difference in systematic review of PEP in cystic fibrosis in short-term or long-term studies. So the long-term studies is actually showing that there is an equivocal or conflict result in terms of FEV1 comparing low pressure PEP with other airway clearance technique. Okay, move on. The fourth thing is high pressure positive expiratory pressure is usually undertaken in a sitting position, which I have mentioned earlier, where the patient is recommended to perform approximately 8 to 10 times breath at a moderate tidal volume. So why they perform this is sitting position is the patient will feel more comfortable in this position. So that's the reason they put the patient in this sitting position. So high pressure positive expiratory pressure demonstrate lung function. Images have been demonstrated lung function improvement, greater sputum production, and also help to reduce or decrease airway stability and hyperinflation when compared to the conventional physiotherapy, which means it can be concluded that a long-term study. Okay, according to Pryor and Prasad, mentioned that these two researchers that mentioned that high pressure PEP is not suitable for patients who are tired easily as it takes effort. So it means that these two authors or researchers, they came out with the conclusion saying that PEP is not suitable for the patient who easily getting fatigue or tired. Because it takes more efforts for them to perform this particular technique. So move on. Baby with PEP reported to be as effective as postural drainage and percussion in infants. Okay, that's all for my part. Thank you, and then I'll pass through the next presenter. Thank you.
The second PICO question would be, which is more effective between chest physiotherapy and exercise in improving aerobic capacity among patients with cystic fibrosis? We have chosen a CPG as our evidence to this question, and the title will be Standard of Care and Good Clinical Practice for Physiotherapy Management of Cystic Fibrosis, 3rd edition, April 2017. We have used the Agree-to tool to appraise the CPG, and for the first domain, the score would be 47.2%, second domain 26.9%, third domain 43.4%, fourth domain 92.6%, fifth domain 84.7%, and the last domain, sixth domain, would be 100%. So the CPG has a low risk of bias and high quality. It provides two types of physical training such as endurance and resistance training, which help improve the activity of daily living of people with cystic fibrosis, and it is the highest level of evidence available with proper data collection and people from different expertise involved to appraise the data collected and to form the CPG. For the main findings, physical training results in positive effect on the pulmonary function, exercise capacity, muscle strength, and health-related quality of life. The CPG provides guidelines to physical training such as the recommended time, intensity, frequency, and type for people with cystic fibrosis, and the risks associated with specific exercise are also mentioned in the CPG. So strength and weakness of article. So first I'll talk about the strength. When it comes to comparing two different types of intervention, this CPG is useful as it provides clear recommendation for many conditions in cystic fibrosis. Second, for other treatments for cystic fibrosis, it is well explained with the expected results given. And lastly, the guidelines are being updated and reviewed by experts who work with or treat patients with cystic fibrosis. And the weakness would be there is no proper method or shown or stated on how the grading is done, and the appraiser can be biased because the grading tools were not specified. And as we know, the CPG is very long and it takes time to read, and reviewer might have not read it and take it as a guideline. So the reason why we choose this CPG is because it is a relatively good CPG on care for cystic fibrosis patient, as after we use the Agree-to tool to appraise it, and when comparing between postural drainage and PEP, based on the level of recommendations, the PEP is found to be more recommended, and the CPG gives good explanation of evidence that support the recommendation of the intervention along with the outcomes and explanation on how the interventions it works. So furthermore, this CPG has a low risk of bias, and it is not funded by other funding bodies, and there are people from different expertise gathered to appraise and forming this CPG.
Evidence with practice for our assignment. So number one is PEP, positive expiratory pressure. What is a positive expiratory pressure is it prevents the airway from closing by creating a pressure in the lungs. So actually it actually helps in increasing the FRC, increase the independence between the alveoli and promoting collateral ventilation flow to prevent previously obstructed passages. In the CPG that we've selected, it was stated that the periods of PEP breathing are combined with forced expiration and cough to facilitate a better airway clearance. And clinically, low pressure PEP is commonly used compared to high pressure PEP. And these are the common PEP devices used: Paris system, TheraPrep, and also bubble PEP, or PEP bottle. Okay, the methods. The methods of using this PEP is like the diameter and the resistor is determined for each of the patients, and it varies according to patient's age and actually. And the steady PEP is given of 10 to 20 cm H2O by the therapist. Daniel stated in his journal once that the originally defined breathing with a PEP is 10 to 25 cm H2O, but this definition was expanded for Cochrane review in 2006 to include 5 to 25 cm H2O. Okay, the instructions to the patient. So this treatment is commonly done in sitting or postural Janice position if it's possible. And first you have to relax and let go your stomach muscles and take a few normal breaths before using the PEP device. You have to put the mouthpiece to your mouth and seal it over the PEP, and then you have to take a bigger breath to your nose and blow through the device, and you will be feeling vibrations. And the cycle has to be repeated from 8 to 10 times. And this process is repeated, and the number of cycles and exact routine of PEP is usually recommended 10 to 20 minutes or until all the sputums are cleared. Okay, another training is resistance training. Another intervention is resistance training. Okay, why do we do this resistance training is to increase the muscular strength, to increase the aerobic capacity, which is endurance, and it is important in cystic fibrosis patient to prevent disuse of atrophy. Okay, the recommendations that we have here is from our CPG. So the resistance it's recommended that the adult cystic fibrosis patient to make resistant exercise as a complement and not a replacement for aerobic, and the frequency that's recommended is 2 or more non-consecutive days of the week. The preferred mode will be weight training to optimize the health benefits, and the examples of weight training is resistive band, free weights, weight missions, and resistance balls are considered. And usually this training is focused more on both upper limb and lower limbs. The intensity is recommended to be 60% to 70% of a patient's 1 RM to improve the muscular strength, and whereas for endurance the load should be less than 70% of 1 RM. The risk that associate with the CF is according to AAP guidelines. Okay, so the powerlifting and maximal lift should be avoided, and prolonged exercise will cause dehydration and hyponatremia. So to reduce this, they have to avoid working out in hot and very hot weather, and also they have to drink plenty of waters. So this will reduce the exercise capacity if they get if they get dehydrated or hyponatremia. They will reduce exercise capacity, and it will lead to increased mucus viscosity and increased risk of exacerbation. Prolonged exercise also may increase the risk of hyperglycemia in certain patients. Okay, and also high altitude exercises will will result in increasing of the risk of desaturation and right heart failure. And these are the examples of latissimus, examples of resistor training for upper limb and lower limb. So the upper limb will be latissimus pull and the lower limb will be quads leg extension. So this is done with the resistive machines. Okay, that's all. Thank you.
And now moving on to cardiorespiratory fitness, or also known as aerobic fitness. So cardiorespiratory or aerobic fitness is defined as the ability to supply oxygen and nutrients to the body tissues. Having good cardiorespiratory fitness helps to slow down the rate of lung function. Not only that, it improves a person's quality of life. Also, it reduces all-cause mortality, and lastly, it also helps to increase aerobic capacity of an individual. So next, according to the evidence in the Clinical Practice Guidelines, or CPG, the cardiorespiratory or aerobic fitness, you can see that for the first component, for the moderate intensity physical activity, it should be performed for at least 150 minutes in a week. And then next, moving on, for vigorous intensity exercises, it should be performed for at least 75 minutes in a week. So this amount of exercise, or this period of exercise, is recommended for adults with cystic fibrosis. So moving on, to elaborate further, for moderate intensity exercise, how it is done is that the patient performs the exercise at 40 to 59% of their peak aerobic capacity, which has been measured on the cardiopulmonary test. On the other hand, the patient performs the exercise at self-reported perceived exertion, which is a rating between 11 to 13 by measuring it using a Borg perceived exertion scale. So the Borg perceived exertion scale consists of 15 item scale, which ranges between 6 to 12 as an exercise prescription. So moderate intensity exercise is also for patients exercise at the rating of perceived shortness of breath between the range of 3 to 4, which has been measured by the modified Borg breathlessness scale with the range of 0 to 10. So examples of moderate intensity exercise would be brisk walking or even just slow jogging. So to elaborate further on vigorous intensity exercise, so this is when the patient should perform the exercise at 60 to 85% of their peak aerobic capacity, in which this also will be measured on a cardiopulmonary test. And then next, the patient shall perform the exercise at self-reported perceived exertion with the ratings between 14 to 16 by measuring it using the Borg perceived exertion scale, same as the previous. So for the patient who has reached the recommended amount of physical training for more than 6 months, it will be considered to actually start physical activity at high intensities. So examples of exercise for vigorous intensity exercise would be aerobic dancing, cycling, and also running. So moving on to the last component of EBP, which is evaluating the effectivity of the process. So for evaluating the effectivity of a process, since we have two PICO questions which are measuring two different outcomes, we'll talk about each outcome separately. So the first outcome would be of PICO question 1. So PICO question 1's outcome would be airway clearance or mucous clearance. So the intervention that we have chosen would be PEP. So the outcome measure that we have chosen for PEP, or airway clearance specifically, would be spirometry. So spirometry test is used to assess pulmonary functions in respiratory physiotherapy interventions. Actually, the population used for spirometry tests is not only for respiratory physiotherapy interventions, but specifically for the diagnosis and monitoring of patients with lung diseases that could be obstructive, could be restrictive, or even a mixture of obstructive and restrictive. Not only that, it is also for the evaluation of any lung impairments. So next, what it measures. So a spirometry assessment is used to measure the volume of airflow in and out of a patient's lung in a specific time, whereby actually this is a time where the patients are required to actually blow into a spirometer. So a spirometry can actually measure many different volumes of the lungs, and some of which the main volumes are listed in the slide here. So first we'll start off with forced vital capacity, or FVC. So forced vital capacity is a volume of air that can be exhaled forcefully from the lungs after a maximum inspiration. Then slow vital capacity is the same as forced vital capacity, but this is when the air is exhaled slowly. So next, moving on to FEV1. So FEV1 is a volume of air expired during the first second of a FVC. So next is FEF, 25% to 75%, which is the flow of air moving out of the lungs in the middle part of a forced expiration. And lastly, the ratio of FEV1 to FVC, in which most young healthy adults can forcibly blow out 80% of their vital capacity within the first second of expiration. So this FEV1 to FVC ratio can be used to depict any lung diseases. Okay, so the main measures that we will take into consideration will be FEV1, FVC, FEF, and the ratio of FEV1 to FVC, because these are the main volumes that we can determine in the severity of cystic fibrosis in patients. So for the scoring procedures and score interpretation, so the results of a spirometry test is different for every individual, as actually the results are based on each individual's age, sex, height, and race. Hence, any obtained results are always compared with the predicted values expected of that sex, that height, and that age to determine whether they fall in the normal range or has any restrictive, obstructive, or any mixed restrictive and obstructive disorders. So we'll talk about each component that was stated as important for cystic fibrosis patients. So the three components that we'll focus on will be FVC, FEV1, and the ratio of FEV1 to FVC. So talking about FVC, so FVC, a lower FVC measurement compared to the normal values indicates that the person's breathing is restricted. So the results of children and adults are actually different and hence are evaluated differently. So abnormal FVC values could be an indicator of restrictive or obstructive, or a mixture of restrictive and obstructive lung diseases. So further assessments of other results of a spirometry test helps to determine which type of lung diseases is present. So what you can see is that the results of children between 5 to 18 years old and the results of adults above 18 years old are different. So for results of children, as long as it is more than 80% or more, it's considered normal. And then so for adults above 18 years old, as long as is greater than or equal to the lower limit of the normal, then it's normal. So next, moving on to FEV1. So FEV1, for FEV1, a lower FEV1 compared to the normal value can indicate a breathing obstruction. So FEV1 results are actually used to determine how severe any abnormalities are. So how to judge whether a person's FEV1 is low, we can go by, we can always follow according to the American Thoracic Society or ATS, or in short ATS guidelines. So FEV1 spirometry tests, what you can see is that starting when it's 80% or greater, it will be normal, and then when it's 70 or 79%, it'll start to be mildly abnormal, and then that will just follow on through, and it'll just get more and more severely, up to the point it reaches severely abnormal. Okay, so next we'll look at the third and last main component for a CF patient, which will be the FEV1 over FVC. So the FEV1 over FVC ratio is always calculated after measuring FVC and FEV1 separately. So what this ratio represents is that it represents the percentage of lung capacity that can be exhaled in 1 second. So the higher the ratio of FEV1 to FVC means the less the likelihood of any lung obstructions. A lower ratio would mean that there is a blockage in the airways. So the normal values that you can see is in the slide, which would say that for 5 to 18 years old, a low FEV1 to FVC ratio will be less than 85%, and then in adults it will be less than 70%. So moving on, so what you can get from the results of a spirometry test for specifically CF patients is that in CF patients specifically, they have a mix of obstructive and restrictive lung characteristics. So why they have these characteristics is because for obstructed airways, it's usually caused by a reduced airway clearance due to thick mucus produced in CF patients, hence reducing the speed of the air that they exhale. So what this causes is it results in a lower FEV1 and a lower FEV1 to FVC ratio. So in CF patients, they also have restricted airways, which may be caused by any fibrosis or scarring in the CF patient's lungs, in which means that there is a decreased lung capacity, resulting in a lower FVC and lower FEV1. Overall, a CF patient tends to have a lower lung capacity caused by a lower FVC, an extremely low FEV1 that is much lower than the FVC, and also a low FEV1 over FVC. So overall, from FVC, FEV1 to, and also the ratio of FEV1 to FVC, everything is lower compared to the normal. So next, we'll talk about the validity and reliability of this spirometry. So spirometry is often taken as the gold standards for assessing the effects of pulmonary interventions, and is considered but as of now, it is considered as a not a sensitive measure in respiratory physiotherapy. This is because the results of a spirometry depends on many factors that are either hard to control or not related to the intervention itself, or even both. Although that is the case, it is still a robust interpreter of mortality, and hence it should remain as the primary outcome measure. Although this is controversial because there are many researchers that could argue otherwise, but ultimately we still chose spirometry. And then actually what can be said is that right now, most of the currently existing clinical outcome measures are not specifically associated with respiratory physiotherapy interventions, and most of the tests right now can be influenced by external factors, which means that there are actually no actual gold standards in outcome measure of airway clearance. So at the end, we chose spirometry because although it is not a sensitive measure, but it is a good interpreter of mortality. So moving on to PICO question 2.
I'll now talk about the validity and reliability of spirometry. So the spirometry is actually the gold standard of measurements, and it is also the most common method that is used. But it is not a sensitive measure, so it is not reliable, as it has many factors that are hard to control that might influence the result of spirometry. So the next one will be the outcome of PICO question 2. So what we use to evaluate the outcome is the CPET, cardiopulmonary exercise testing. It is actually a laboratory-based test that involves a detailed evaluation of a patient's respiratory, musculoskeletal, and also cardiovascular system physiological responses. So the target population this CPET meant to use is actually for patients that they have any respiratory or cardiac disorders, and also for patients that are prior to surgery, and also for them during rehabilitation with major disorders. So what does CPET measures? It actually measures heart performance. ECG test is done prior to, during, and also post-exercise. It also measures blood pressure, also prior to, during, and also post-exercise. Also measures respiratory oxygen consumption, which is known as VO2, and also measures respiratory carbon dioxide consumption, VCO2, and also measures respiratory carbon dioxide production, VCO2, and also measures the lung function. It measures the flow volume loops, lung strength, and also the lung capacity prior to, during, and also post-exercise. It also measures the anaerobic threshold and also the ABG. ABG is measured by taking a blood sample from the artery, and that is used for laboratory tests. So what is expected in cystic fibrosis patient is there will be increase in alveolar ventilation. So why does it happen? It's because it is caused by increased dead spaces due to the mucus production in cystic fibrosis patients. And increased alveolar ventilation is because they want to meet the ventilatory demands. There will be also increase in respiratory muscles effort in cystic fibrosis patient as they have increased mucus production. So there will be it will result in airway obstruction. More inspiratory airflow must be generated to compensate for faster gas exchange. So more effort is needed from the respiratory muscle to obtain the same ventilation as the normal person has. There will be also increase in VO2 requirements of cystic fibrosis patient compared to normal person, as it is caused by increased work of breathing. And the increased work of breathing is caused by compensation for alveolar ventilation. So for the validity and reliability of CPET, in CPET, breath-by-breath ventilatory gas analysis is done, which allows for more precise measurement of VO2 max. It is more reliable and also valid from the other exercise testing. It is a gold standard for exercise testing in cystic fibrosis patients. It has very low risk of cystic fibrosis patients developing any other symptoms while doing the testing. So these are the references that we use to develop our plan and also the evaluation for our cystic fibrosis patients case. Thank you for watching and also thank you for listening. Bye bye.